Good afternoon and welcome to today's webinar titled IT Strategies to Improve Clinical Communication, Alarm Management and Safety, presented by Healthcare Innovation. My name is Rajiv Leventhal. I'm the Managing Editor at Healthcare Innovation. Today's program is sponsored by Vocera. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we do have a few housekeeping details to go over. First, to submit a question, please use the Q&A box to the left of your video window at any time. You don't have to wait until the end of the program to submit a question. For technical issues, you can press F5 to refresh, and if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, we encourage you to join our conversation, our webinar conversation on Twitter today, and you can tweet using the hashtag HILiveWebinar. At this time, I'd like to introduce our expert speaker for today's program. We have with us, and we're delighted to have with us, Dr. Benjamin Kanter, who is a pulmonary and critical care physician and the Chief Medical Information Officer at Vocera, where he works closely with clinicians and engineers to co-design the next generation of real-time communication and collaboration solutions for hospitals and health systems. Dr. Kanter has had a focused interest on healthcare communications for the past 14 years. And with that, Dr. Kanter, the floor is yours.
Thank you. Thank you for spending time with me today, and thank you, Rajiv and Healthcare Innovations, for the kind introduction and for hosting this event. We only have a short time together, so I'm going to jump right in by illuminating a problem you're likely well aware of, the increasingly disruptive avalanche of information confronting, if not actually overwhelming, frontline care team members. As I'm sure most, if not all of you would agree, the environment your nurses work in can be considered chaotic, pressure-packed, and interruption-driven. Almost every system you implement today has an ability to send messages, alarms, about the status of a patient or the status of the system itself. Understandably, these messages are often routed directly to the nurse who's responsible for the relevant patient. And this is done with the best of intentions. Get information about a patient to the right person who's positioned and licensed to act as swiftly as possible. Each system wants to avoid potential sources of delay because of the recognition that the quicker a clinician can respond to a change in a patient's condition, the better chance there's going to be a good outcome. And the same holds true for hospitals. The sooner a hospital can process data and respond to areas of operational friction, the better. Here's another image that unfortunately you may have had some firsthand experience with over the past year, the inability of staff to remain in contact with their team members when caring for a patient who's in isolation, i.e. who has COVID or any other communicable disease. In this situation, the nurse or physician or respiratory therapist is just as isolated as the patient, and that's not a good thing for multiple important reasons, and this is a problem we'll be returning to later in the presentation. So, as previously pointed out, modern hospital systems, whether clinical or operational, have an increased capability which allows them to communicate directly with frontline team members. And as previously mentioned, although this is done with safety and efficiency in mind, the reality is that these systems don't talk to each other. They each exist in their own silo. The end result is a situation where the unfortunate nurse can get hammered by uncoordinated interruptions. So if you forget the traditional idea of alarm fatigue and instead focus on interruption fatigue, well, when you do that, you immediately recognize that there are all sorts of sources of interruption and that alarms are only a subset. This graphic highlights rather standard sources of interruption, but there's something accelerating down the road that's going to ramp this up, the so-called 5G revolution. 5G promises to increase bandwidth, reduce latency, increase trust, and increase network survivability. If you think you've got a handle on the Internet of Medical Things today, wait until the number of monitoring devices explodes to take advantage of 5G. What 5G does not promise is to magically increase a nurse or physician's ability to absorb all of that new information, whether it's actionable or not. This isn't a problem that can be solved by simply tacking on these new systems and their new alarms onto your existing communication infrastructure. It's going to take careful, thoughtful planning and execution. In a prior life, I had an opportunity to study the tolerance of nursing staff to new meaningful interruptions, and it's a surprisingly limited capacity. If you assume, and this is very conservative, that nurses were being interrupted about 5 times an hour prior to the introduction of smartphones, then there's only a small residual capacity to absorb more information before the disruptions overwhelm any benefit of the new information. So even if you take on the challenge of 5G successfully from a technical standpoint, will you be increasing cognitive assistance or increasing cognitive disruption? How much more information can you push out to your users using current methods before they rebel? Well, I mentioned that to solve this, you're going to need thoughtful planning and execution, and the solution is to become what's known as a smart hospital or real-time health system. These concepts both refer to healthcare operations which have an ability to leverage their investment in digital technologies to discover novel insights and respond to areas of operational and clinical friction in real time, shortening the time to act. And a foundational component of a smart hospital is their communication and collaboration platform, or CC&C, without which knowledge can't be turned into action. Your hospital, no matter how talented your analytics or information processing teams are, without a modern communication platform will never be able to react and resolve issues quickly enough. What's needed is a communication platform that can receive data from multiple different systems simultaneously and arbitrate the work, determine the relative priorities, and then distribute the work to the right person or teams. The analogy of an air traffic controller is one that's commonly used. You need a system that can make sense out of chaos and ensure that the right information flows to the right people. Well, how is this accomplished? We'll spend some time and examine how Vocera's CC&C platform fulfills this need and becomes that fundamental component when building your smarter hospital. At a high level, a CC&C platform is made up of 3 elements: inputs, a processing layer, and outputs. Vocera's CC&C suite provides a unified solution for hands-free voice calling, secure texting, alarm processing, and routing, along with the expected audit and reporting tools. Now, on the left, you see the inputs. Various hospital systems as well as staff provide inputs to the system, and just to give you some perspective, our platform already has adapters or interfaces for about 150 different hospital systems. All of this serves as input to the main platform's intelligence, which is really where the important actions take place. The goal isn't to simply connect information to people. That's not particularly intelligent and wouldn't reduce the cognitive overload experienced by nurses. We need to do more than simply route data to staff. We need to orchestrate the work if we're to ease the caregiver's day while shortening response times. And there's a lot going on in the middle. The platform aggregates data streaming in from the various systems. That data can be integrated, so the data that ordinarily exists in silos can be merged and processed together, and then by using rules converted into information which may or may not require action. This is an important point. Just because information exists doesn't mean it should be communicated. An intelligent CC&C system understands that knowing when not to send a message, knowing when not to interrupt a caregiver, is just as important as knowing when messages should be sent. When a rule declares that information needs to be transmitted, the system acts by routing it to the right person or team based upon role and responsibility. The same platform constructs the audit trail and provides the analytics and reporting services. Given data feeds from care team assignment systems, integrations with the electronic health record, and scheduling systems, we're able to construct a dynamic care team, basically tracking who's currently working, what roles they've got, which patients they're caring for, their present status, are they currently available or not? Understanding present status is critical. Construction of this real-time care team is crucial to our ability to deliver the right information to the right people and to reducing interruption fatigue. Finally, on the right side are the outputs. Modern communication platforms can message one or more people one or more ways, with both manual and automated escalations built in. If a nurse is unable or unwilling to respond, messages are automatically rerouted until delivery takes place. Importantly, a CC&C suite should be agnostic as to the mix of devices your staff needs to use to accomplish their job. Each role in the hospital has uniquely associated workflows, so each role will have a device which best enables communication to take place, if you will, a best tool for the job. While neither the EHR nor the communication platform should constrain your choices in this regard. If you artificially limit the types of devices used by your staff to communicate, you limit how smart your hospital can become. Now, many users are equipped with smartphones. And while this had historically been the provenance of physicians, it's increasingly commonplace for nurses as well, using enterprise provision devices. Vocera's Avena application runs on both iOS and Android platforms, giving the user complete access to all of the functionality of our platform. The solution was developed in partnership with our user community, truly an experience that has been designed by clinicians for clinicians. It isn't just about creating a secure text messaging platform. Physicians and nurses receive different types of messages and have some unique needs. As but one example, the inbox message order is not based solely upon which message happened to come in last. Rather, it's a prioritized inbox, which recognizes that the newest message may not be the most important message. Now, you may have noticed I didn't mention pagers. Smartphone replacement of pagers offers three major advantages, and the first is security. While our system can send information directly to paging systems, there are privacy issues with old paging technology, as exposed in a Western Australia data breach last July. The system was hacked by essentially a child. And lest you think it can't happen here, this is from August 2020, here in my hometown of San Diego. A security researcher was able to read all of the information contained in conversations from a hospital taking place over alphanumeric pagers. And per the CNET article, Brown, the researcher, was able to see it all, including personal details about patients, like patient names and their COVID-19 status, as well as how often patients were transferred from the coronavirus wing to the morgue. The sensitive details were being sent without encryption over hospital pagers, Brown said, allowing him to eavesdrop on private conversations from March to August. Second advantage of pager replacement is the speed with which emergency teams can be mobilized. Using a communication platform like ours, you can, as an example, have code teams triggered via direct integration with your nurse call system or from a clinician's smartphone or from a web-based console. By doing so, you remove sources of delay. For example, there's no need to call the PBX or the main operator. At this hospital in the United Kingdom, by implementing our system, they found that mobilization of their Code Blue team was shortened from 2 minutes to 20 seconds. And finally, there are the other issues with pagers you've all experienced. When someone's paged, there's no visible audit trail. You don't know if the page has been received, if it's been read, if the recipient's going to respond, etc. As opposed to pagers, when using smartphones and the Vocera app, it's very clear who's received the information, when the information was delivered, and when it was read. And since our system allows you to include an optional button press for the recipient to respond with a "Yes, I'm coming," or "No, I'm not," the person who's activated the code team or the cath lab team or any other emergency action group will know who's going to respond and who isn't. Now, in addition to our smartphone app, Cosera has been making hands-free communication equipment for approximately 20 years. The B3000N device on the left is now in its 4th generation. And although its primary users are generally nurses, they're also in use by hospital-based physicians. It's small, lightweight, and worn either on a lanyard or clipped to a shirt or jacket. The device to its right is the newer Vocera Smart Badge, which has a larger touchscreen, making it a better fit for heavy text messaging users. It has all of the functionality of the B3000 as well as an ability to be awakened using a smart phrase, such as, "Okay, Vocera," after which it will wake up and respond to voice commands. Both devices were designed specifically for use in healthcare and are easier, more efficient, and more economical to use than smartphones. Importantly, because these badges can be worn and used underneath PPE, they become critical technology for patient care in isolation environments and for caring for COVID patients. The impact COVID has had on physicians and nurses is very personal for me. My daughter Rachel is a nurse at a major East Coast academic medical center, and among her responsibilities has been managing COVID testing sites as well as vaccination centers. My wife is an infection preventionist. She and I have been volunteering at our city's vaccination center. When you read studies focusing on the effectiveness or lack thereof of PPE, there's one glaring message that stands out. No matter how well trained your staff or well-intentioned the PPE design, the technology is far from perfect. Self-contamination is remarkably common when removing, or what's called doffing, your PPE. But what are the implications for communications technology? Well, if self-contamination is a probable outcome when wearing PPE is commonplace, then an optimal approach is one that minimizes the need to remove PPE once it's been put on. Consider other first responders, other frontline staff. Do police or firefighters go into action without a radio to keep their teams in communication, or to communicate if their own safety is threatened? Of course not. Yet that's exactly what we've been expecting from our physicians and nurses. If you're wearing PPE and in a patient's room, if you need to communicate with your team, or if someone needs to speak with you, you have to stop caring for the patient. Remove your PPE, wash your hands, and then you can pick up a phone or call for assistance for an x-ray, for a lab draw, or to conference with other physicians and nurses. Requiring your staff to remove PPE in order to stay connected increases PPE waste, exposes the clinician to a risk of self-contamination, and chews up valuable time. Your staff shouldn't have to risk contamination in order to have communication. When you isolate your staff physically, there's no reason to simultaneously isolate them technologically. Now finally, like COVID, and this is a topic I wish I didn't have to include, but protecting the physical and emotional safety of healthcare workers has become an international challenge. Both badge types offer built-in duress or panic button features that can be custom mapped to responders appropriate for their location. Once triggered, the recipient or recipients of the panic call can hear everything that's going on around the person who triggered the call. The microphones on the badge are automatically switched to an omnidirectional mode, so they'll pick up all of the ambient sound in the area around the person in trouble. And the badge wearer's location can be determined based on the access points they're connected to. By way of a few examples, at SUNY, they had a real problem with violence in their emergency department. And when they implemented our communication badges, the duress functionality was set up to notify both campus police and hospital security members. By doing so, they dramatically reduced the time to respond to staff members in jeopardy. At Niagara Health, the number of people injured in aggressive incidents decreased by 20%, and at Toronto East, they saw a reduction in response time very similar to that experienced at SUNY. Now, it looks like we have some time for a few other quick case studies. At Major Health Partners in Indiana, they moved from a 150,000 square foot hospital to one that was twice its size. They were confronted with a noisy environment, information overload, alarm fatigue, and communication challenges. After implementation of the Vocera platform, they noticed a reduction in environmental noise, improvement in patient satisfaction, improvement in on-time surgical starts, and improved benchmarking in the ED. at Metro Health, a University of Michigan affiliate, they were looking for a solution that would enable care teams to communicate instantly in critical situations. When they looked at the impact on their stroke metrics, they saw profound improvements in door-to-needle time, door-to-groin time, and door-to-recanalization time. And for sepsis, at Augusta Health in Virginia, they estimate that using Vocera to automatically deliver their sepsis alerts directly to the badges and smartphones of appropriate team members has saved 355 lives and significantly reduced their sepsis mortality rate compared to other hospitals in Virginia. So to wrap things up, a smart hospital efficiently recognizes and reacts to new clinical and operational information quickly and efficiently. But in order to accomplish this requires a modern communication platform so that the knowledge can be transmitted and acted on. And by shortening the time to act, your operations are streamlined and patient outcomes are improved. And to accomplish this, your communication and collaboration system has to be capable of integrations with multiple different systems, discerning what needs attention and what doesn't, and intelligently distributing that information to those responsible for taking action. This is the process that makes interoperability a reality. This is the process that makes your hospitals more efficient. This is the process by which patient outcomes are improved while simultaneously reducing the communication burden for your physicians and nurses. And with that, that's the end of my formal presentation. Rajiv, I think we have time to address questions and answers.
Yeah, absolutely. And thank you, Dr. Kanter, for a very informative presentation. We all learned a lot. And as you mentioned, we do have some time for questions from the audience. We've already had some come in, but we'd like to take this time to remind you to use the Q&A box to the left of your video window at any time to submit a question from now until the end of the program. The first question for you, Dr. Kanter. Many hospitals are trying to update their infrastructures to become smarter, quote unquote smarter, as you talked about. What advice would you give to IT professionals tasked with this goal?
In my view, and I'm going to focus for now at least on communications. Communications, although it obviously squarely lies in the IT portfolio of maintaining your telecom and other communication channels, the reality is that it's a clinical tool. It's a tool used by clinicians in the care of their patients. And I would say from the beginning that you need to have sort of three different groups at the table when you're looking at a strategic enterprise-wide communication initiative. And that is, you obviously need your IT personnel, you need steadfast leadership from your executive team, but you also need membership of your physician and nursing communities because you need clinical leaders that are there at the same time. I would say that's the key. If you get off on the wrong foot, if this is solely an IT effort or it's solely a clinical effort, you can't really be successful in isolation.
Great. Next question, looking towards the future, Dr. Kanter, what do you believe the future landscape of smart hospitals will look like?
Wow. Well, I don't think anyone attending this webinar thinks that the amount of information that's being generated in your hospitals is diminishing. And in fact, it's going to continue to increase, as we mentioned, as more and more devices and sensors come online, enabled in part by the 5G revolution. So if you combine that with our expert systems, and think AI or expert rules, working in partnership with physicians, there's going to be more and more real-time guidance and more messaging taking place. Well, despite the well-meaning intent of getting this information directly to the physicians or nurses, it's going to be difficult because of their limited bandwidth. So it's going to force hospitals to continue to evolve their smarts, or the burnout problem afflicting their staff is going to accelerate. So I think you'll see hospitals becoming increasingly reliant on advanced workflow and decision-making systems, which by necessity will be integrated with their communication platform. So you're going to see more and more technology that is being layered in between the devices and the clinician to offload some of that burden, to do some of that filtering and processing, so that when the information gets to the clinician, it's actionable and important.
Great, thanks. Next question from the audience. If your organization wanted to implement badges for our COVID cases, how complex would that effort be and how much time would it take?
Well, COVID has forced us to evolve in our implementation scheme, just like it has forced adoption in new methods and technologies within hospitals. We can actually stand up a use of our communication platform for COVID in specific limited areas of hospitals in a week. So if you said, hey, we need to stand up a triage tent and we're going to be processing our COVID cases in the emergency room, as an example, we can come in and set up the emergency room, the triage tents, and connect all of the appropriate teams, et cetera, and do all of that in a period of really a week.
Great. Next question from the audience, and just another quick reminder, if you have any questions, feel free to submit one, and you can do that using the box to the left of your video window. Next question, Dr. Kanter, can you explain a little bit more about the panic feature on the badge and smart badge? How would a security person know what the situation is or where to find the person in danger?
Right. Well, so if I'm a physician or a nurse who is in a situation where I feel my safety or the safety of others is threatened, I can push the duress button, if you will, and nothing appears different to the person who I'm in the room with. So the person who may be agitated won't get further agitated. There won't be a worsening of the situation. But what it does is it automatically places a call directly to the security personnel who are connected automatically, and the badges have usually they have microphones that are set as directional, so they really are listening for whatever the wearer is saying. In this case, those microphones are now picking up all the ambient noise. So the person who's responding, the security guard as an example, can hear all of the discussions that are taking place in the room. That allows the person wearing the badge to say things like, Mr. Smith, please calm down. We don't act this way in the emergency room, or we don't act this way in room 306. So they can tell exactly what's going on, and they can get subtle hints, or sometimes not so subtle hints, about where that altercation is taking place. But also we have the ability for the person who's responding to simply tap their badge and say, locate Ben Kanter, in which case it would be able to tell them exactly where I'm located based on the access. So it's not room level, but it's access point level about where I'm located. So in this case, it might indicate that I'm at a specific part of the emergency department, allows the security to then respond to my immediate region. I hope that answered the question.
Yeah, absolutely. Next question, what has been the biggest challenge or challenges to adoption?
Well, the biggest challenge to adoption is often when you don't have all the players at the table from the beginning. As I mentioned at the start, if you don't have your clinicians at the table with IT, it really creates issues. From an adoption standpoint, physicians and nurses have different needs, and it is much easier from a change management situation to put systems in place that are mandated for use by your employed nurses, but it's much more difficult to cajole your medical staff into using the same systems, because in many hospitals the physicians are not employed, and the physicians are sort of free to do what they want as long as they're not running afoul of their medical executive committee or other rules. So getting physician adoption is tougher, and there you do need strong internal clinical champions that really help to move things along. I would say another part of the challenge is you have to be very careful with your nursing staff. And I mean careful because the nurses are already being interrupted a lot. And they now have smartphones or other devices. And so you want to be very careful about how you manage additional sources of information coming to them. And so I think it's important to align your initiatives with your CNIO, if the hospital has them, or make sure you have a dedicated representation, a dedicated representative of nursing who's part of this process, who can help make sure that the staff transitions well when they're starting to get more clinical information pushed directly to them.
Great, and I think with that, we've run through our questions, but I'd like to take this time to once again thank Dr. Kanter for an extremely informative presentation and for sticking with us to answer some audience questions. It really was an excellent webinar. I'd also like to thank our sponsor, Vocera, for making today's program possible. And finally, last but not least, I'd like to thank everyone in our audience for joining us today. We really hope you'll join us in the future for another healthcare innovation webinar. And with that, this concludes today's presentation.